Thank you very much for coming. I do appreciate that. Our final group, it's great having you here. Today we're going to talk about the dementia and how it might affect you working as an EMS. All right, as he said, I'm Jan Zimmerman. I'm the Administrative Director of Nursing for Heritage Homes here in Watertown. I'm also the President of the Watertown Dementia Awareness Coalition. So here's my contact information if you have any questions, need some help with anything. Don't know all the answers, but I do know where to get a lot of the answers, so I'll help you any way I can. Okay, how many of you have heard of the Watertown Dementia Awareness Coalition? Hey, 3. That's 3 more than I had last time. So that's really good. This started about a year ago. I get a lot of questions from people, what is dementia? My mom is doing this, what do I do? Heritage Homes has a dedicated memory care unit, and we get questions from family members, but we also get a lot of questions from the community. And so every year we were doing some type of an educational program so that we could go out and share our education with family members, those living with dementia, friends, professionals, etc. So last year when we were looking at what we wanted to do, we realized we really hadn't touched on businesses and services in the community. So we went online and tried to find what people are doing in the United States, and there was very little, if anything, there. So we decided that we were going to move beyond just doing a 1 or 2 hour presentation and look at what we could do to make Watertown more dementia aware, more dementia friendly. Wisconsin has got about 190,000 people right now with a diagnosis of dementia. By year 2025, we're expecting at least 201,000. Watertown has got a high aging population here because of the housing and things. So this is really going to be affecting Watertown, and it's going to be affecting you more and more as we go forward. So our goal for the Watertown Dementia Awareness Coalition is to increase the community awareness. And how we're going to do that is we're providing education. We're doing things like coming here today. We're going into the different businesses, banking, restaurants, pharmacies, etc. And also with the community doing education sessions for them. By providing that education, we anticipate that we're going to decrease the stigma that still surrounds those living with dementia. It's another area that people are afraid of the diagnosis. They don't want to hear it. They don't go to the doctor. They don't want to admit that they're having memory problems. Physicians who've maybe worked with them for 20, 30, 40 years don't want to give them this diagnosis. So when we were talking about the numbers before, those are those who are diagnosed. At least 20% of those with early signs of dementia are missed by the physicians, and a lot of them out there just won't even go to the physician to get that diagnosis. So therefore, we know that the number is much higher than what we have. And if we can decrease the stigma associated with memory loss, that will enable people with dementia to live fulfilled lives out in the community as long as they want to. So what we plan to do is we want to work with local services and businesses to help our local community become dementia friendly and a fulfilling place to live for people with dementia and their care partners. This is a disease that really affects those around them, much more so than any other disease. When they start to isolate because they're having problems out in the community, their care partners isolate because they can't leave the person at home by themselves. So pretty soon you've got a number of people who are staying at home and not going out in the community. We want to increase local opportunities for people with dementia so they can continue to enjoy their chosen activities and interests for as long as they wish to. One of the things that we have started is the Memory Cafe. I don't know if any of you have heard of that yet. It's at the Connection Cafe. It's the 3rd Wednesday of every month. And it's a social support group. It's not a therapeutic, but it's a place where somebody with dementia and their care partners can go and be a couple again. It's a social outlet. Nobody cares if they're not finding the right word, if they forget what they're saying in the middle, because everybody's in that situation. So they come, they laugh, they cry, they talk about what works really well, what isn't working. Sometimes we talk about totally off the topic, like how do you diaper a baby, the old cloth way versus the new disposable, but that's what they want to do. And so they're coming out. We had it last Wednesday, and even though that weather was so cold, we had 7 people there. And I was kind of sure we weren't going to have anybody, but they want that social outlet. And because of all these changes, we're going to challenge the myths and stigma associated with dementia, which act as our barriers to change. Okay, how many of you have had any experiences working with somebody with dementia confusion? 1 or 2? Yeah. You want to share any of those?
I think the biggest thing for us is in this field, we do always encounter people that may have been diagnosed with dementia or in the early stages of dementia. I've encountered people that have been confused and didn't know where they were at a local bank, to someone being found after 24 hours and they were just in their car driving around, and to someone that was pretty combative, thinking it was this frail 86-year-old guy thinking he was 16 years old and ready to take on the world. So I think that's one of the reasons why we were looking to have you here, is to see how do we interact and work with people when we come into situations like that.
Is that pretty well everybody's experience? Okay. So how do we define dementia? That's the biggest question I get. Exactly what is dementia, and is Alzheimer's the same thing as dementia? Dementia is not a disease. What it is a group of symptoms that form a dementia syndrome. And it can be caused by a number of different things, but what it does is it causes a decline in memory and other thinking skills. And therefore they're having a hard time doing activities of daily living. It will affect memory, language, and the ability to communicate, the ability to concentrate, pay attention, reasoning, judgment, the visual spatial perception. There are changes that occur in the vision, but also how the brain understands what they're seeing. So they may have things like delusions and hallucinations. And then emotional or behavioral responses. So some of the psychological and behavioral issues you might run into is a loss of inhibitions and impulsivity. That means they may come up and just strike you out of the clear blue, or they may come up and hug you out of the clear blue. Especially in the latter stages, they like sensations, and they are drawn to things that are shiny and different. So you may be talking and they'll come up and they'll touch you. And it's like, whoa, what are you doing here? But part of it is they see something, they like it, they're going to touch it, or they want the sensation of your jacket, your glasses, whatever it is. Depression and anxiety, agitation. A lot of times this is due to anxiety and frustration. Balance impairment. They're the ones that are high risk for falls, and those are the ones a lot of time while you're coming in is because somebody has fallen, hit their head, or have a hip problem, shoulder problem, something. You'll see tremors, which again affects how they can do their balance and how they do their activities of daily living. They may have delusions, thinking they're someplace else, thinking maybe a picture. We had one lady that all of a sudden would not go down a hallway, and we had to go down that hallway to her room, and she would cry and she'd hit and she'd swing, and we couldn't figure out what was going on. One day I was walking with her, and all of a sudden she's going snake, 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 snakes, and I'm going, okay, what does this mean? I couldn't figure out what it was. Well, I turned to talk to my coworker, and here was this picture on the wall. And it had these, these vines, and they had some flowers and that kind of stuff. And as she was walking with her delusion and her visual changes, she thought that those were snakes. Took the picture off the wall, and we had no problems going down that hall with her again. So a lot of times they're getting these misperceptions, but they can't always communicate them to you. So sometimes they're acting out, and you're trying to figure out what the. Sometimes you can figure out, sometimes you can't. So just be aware that all behavior is a form of communication. We may not always be able to figure out what it is, but they're always communicating something to us, and we have to try to figure out what it is. And then the hallucinations, especially with the frontal temporal, Lewy body. A lot of times you'll see small kids, animals, men hiding in the room, that type of thing. So one of the things with dementia that makes things so difficult is that there are over 100 different types of dementia out there. So what I talk about is to try to get people to understand what the difference is between dementia and Alzheimer and some of the other ones, is I always say, think of dementia as being a tree. Okay, trees have woody stems, maybe lots of branches, maybe a little taller plant. So we have got an oak tree, a cherry tree, a maple tree, apple, a willow, holly, an orange tree, and a pine tree. They're all trees, right? But they're all different types of trees. So Alzheimer's, the frontal temporal, vascular, PICS, mixed, Creutzfeldt-Jakob, alcohol, Lewy body, they're all dementias, but they're all different, and they all present differently. Thing to realize is dementia is not a normal part of aging. You get that a lot. You get it a lot from the community. You get it a lot still from healthcare professionals. I had a friend who came up to me the other day and was just all upset. It had taken forever, and they finally got their dad to go to the doctor and admit he's been having problems with memory. So he went to the doctor, said, hey, I'm kind of concerned, I'm having memory problems. The doctor looked at him and said, it's okay, you're 80. That's to be expected. So now dad is coming home going, hey, doctor said I'm fine, I don't have to do anything. Well, that really robbed him of the chance of getting a much more in-depth assessment. But also there are some medications, they don't stop the disease, they won't prevent it, it doesn't cure it, but they can slow down the progression. There are physical things you can do, there are nutritional things that you can do, again, that will kind of slow down the progression. Just robbed him of that. So now she and her family are having to start all over from scratch and convincing them he should go to a memory clinic. Aging is the #1 risk for Alzheimer's, more common after the age of 65. The risk is 1 out of 4 after the age of 85, and they're saying that in about 10 years, unless things change, the risk is 1 in 2. So there is a very real possibility that half of you in here will get dementia. The other thing to remember is that people in their 40s and 50s can also get dementia. It's early onset dementia, and we're hearing more and more of earlier. I hear a lot about those in their late 30s. I heard of a couple recently in their mid-20s. And there was one who had this rare syndrome, but she was 8 years old and was diagnosed with Alzheimer's. That's very, very unusual. But you're seeing somebody out on the street, he's in his late 30s, he's being combative, he's calling new names, everything else. You know, #1 thing is you're figuring, oh, it's got to be drugs, alcohol, something along that line. It could be that he has got dementia, and we'll talk about that a little bit more as we go forward. So what are the problems identifying dementia? Very often the early signs are very subtle, they're inconsistent. They have their ups and downs. It's not a straight plane down. It's very curvy. So some days, some weeks they're doing really well, and then they'll get a bad period, and then they have a lot of problems with memory, and then their memory's better again. So it's not really, you can't just pinpoint, you know, like somebody's got diabetes, and you can just check their blood sugar and boom, you know what they have. It's not so with those with dementia. Often it's not diagnosed. We talked about healthcare providers and why we may not do that. What do I mean by it's a relatively new condition? I mean, hasn't it been around for years and years and years? The reason that they say this is even 20 years ago, somebody living into their 70s was not a usual thing. So if the greatest number are after age 80 and 85, all of a sudden we're seeing a huge increase. And as our population ages, we're going to see more and more. Most of you guys are younger, okay? But I'm starting to get up there. So if we've got an aging population, who's left to take care of us? It's going to be you guys. So whatever we can do to help with the research and getting plans in place now is only going to benefit you. And the other reason it's problems identified is there's so many different types and there's so many causes for it. Remember, it's not a normal part of aging. It is a brain failure. You'll hear people just stop it. Or they'll say to me, he's doing this on purpose. He knows it drives me nuts. They really cannot help it. We'll talk about a little bit more later why they can't. But it is a brain failure. You wouldn't tell somebody with asthma, just start breathing right. It's the same thing with them. They can't help it. It's more than just forgetfulness. As you get older, you're going to do some forgetting, especially if there's a lot of stress going on, you're multitasking and things. But you can remember it in a little bit. Like I may go, oh, what's his name? And, oh, I know, I can't think of it. But then 5 minutes later, it's like, oh, Bob, that's his name. So it will come back. Somebody with dementia, they won't get that back. And it makes doing day-to-day things really difficult, next to impossible. So talking a little bit about the brain and how Alzheimer's and dementia affects it, I'm going to spend my time right now on Alzheimer's because that's the most common. 80% of those with a diagnosis of dementia have Alzheimer's. And it starts here, kind of in the middle of the brain, behind the temporal area. There's an organ called the hippocampus. The hippocampus is responsible for your short-term memory. So right now, as I'm talking to you, your brain is taking it in, and it's going to the hippocampus, and your hippocampus says, yeah, I'll hang on to it for a few minutes and see if I want to do anything with this. So it's hanging on to it, and you're going, maybe I'll keep it, and it moves it back a little bit. Well, after a while, because you've used it, you've thought it was really interesting, you think, you know, my mom's having problems, I might want to keep this information. It will then take it and move it into your long-term memory, and that's where you can reach it. Okay? With somebody with dementia, with that part being affected first, you kind of think of it as being a sieve. Okay? You can pour water into it. You'll have some moisture inside, so some stuff clings, but most of it runs through. So the same thing. They can't hold on to what they're hearing and seeing and learning long enough to ever be able to move it to a longer term memory, even to hold it so that it's the next day. They can't do that. So that's why you'll see memory as being the first part with Alzheimer's. Then what it does is it kind of moves out into the temporal lobes here, and this is where you have your language. Now they're having difficulty finding words. They may use the wrong word. Can I have your thing? Your drinky thing. They will go around it, okay? Or they may get to the point that it's like, can I have the pick? Please, could I have your pick? Can I have the pick, please? People are going, what's a pick? You can't figure this out, right? Now, they're sitting there trying to figure out what the person is saying. The person is going, it's obvious I want the pick. Fine, if you won't give me the pick, I'll come over and I'll get the pick myself. Okay, so they get very frustrated because they're not communicating. And this is where you start seeing an increase in agitation. Now you might see yelling, verbal aggression. You might start seeing physical aggression going on. And that's because this area is being affected, and also the parietal lobes. Both of those work in conjunction, thank you, with language. Okay? So now it goes and it moves up into the frontal lobe. Does anybody know what the frontal lobe is for? Frontal lobe is your impulse control. It is your filter. People People don't really develop a fully mature frontal lobe until they're in their 20s. Women, most of the time, it's the early 20s. Men, it's the late 20s. That's why you see some of the behaviors that you will sometimes see, because they don't always have the impulse control, they don't have the filter. We had one lady who, little thing, she was about that high, and I'd go in the morning, I'd go to give her her pills, and I'd say, "Good morning, Susie." And she would give me this string like you wouldn't believe. Call me everything under the name, and I was stupid, and I was ugly, and she was going to report me to the police, you know, this whole bit. And I'd just go, "Oh, okay, here's your pills." Her kids would walk out of the room going, I can't believe Mom just said that. She was a Sunday school teacher. Her husband was a pastor. 2 of her boys were pastors. Another son was a parochial school teacher. Her daughter was a parochial school teacher, married to a pastor. Okay, do you think there was a lot of that language going on in the house? No. And she had that filter in place, but now all of a sudden it was gone, and those are primal words, and they come out. So once that frontal lobe is gone, they will say what they want to say, they will take what they want to take, they will do what they want to do, because there's nothing to stop them. Okay? The parietal lobes, again, we've got the motor cortex, we have the sensory cortex. That's where they start losing some of their sensations, where they are in their world. They will also start having some of the visual problems, so most of that is coming down here. But that where it really starts extending into their communication. Not only are they having problems getting the words out, the expressive, but they have a lot of problems understanding what's being said to them. So you think you're being as clear can be, but they can't process it. Then they move into the occipital lobes here. And this is where you have your vision and the perception there. Most of you, put your arms out at your side. Okay. Now I want you to move them back a little bit and start wiggling your fingers. Wake you all up here. And then start bringing it in, looking straight ahead, and stop when you can see your fingers. Okay. Most of you are younger. As you start getting older, your your field decreases. Somebody with Alzheimer's has a vision field like this. So if you put your hands like this, and this is your world. Everybody put your hands like this. Look at your little binoculars. Okay, can you see a whole lot to the right of you or to the left of you? No. Can you see a whole lot above you or below you? Think about how that shrinks down your world. Having somebody come up from the side, you think, yeah, it's no big, they can see me coming. They may not be able to see you coming. And all of a sudden you say something to them and you might get hit. It's a self-preservation because they're scared, because all of a sudden somebody is there. So we'll talk a little bit later on about how do you approach somebody and what do you do with that. There are also the ones that will walk like this because they can't see. If they're like this, they can't see their feet. They can't see the floor. So they're looking down like this. They're doing the shuffle. They run into things. They fall over because they've hit somebody. Or they've hit somebody with their walker or bumped into them, and that person turns around and swings and hits them or pushes them. Now they've fallen, now they've had their broken hip or whatever. Then finally it comes down into the cerebellum here, and this is your muscle area, muscle control. They have problems with balancing, walking. They start pulling in, their muscles get tight. They have some rigidity. They have problems with the muscle between the ribs, so they can't take deep breaths, so now they're more prone to having pneumonia, aspiration pneumonia, because they're having problems swallowing. They don't have the reflex and things. Being able to hold and pick up things, walking is all very difficult. And then finally, if for some reason they haven't died by this point, it will go into the brainstem, and that deals with your heart rate and your respiratory system, etc. But most of the time, before it gets to that final stage here, they have passed away because of pneumonia, heart attack, something along those lines. One of the things is the brain starts getting affected. They have problems with septicemia, and they won't show as having an infection. If you get an infection in your body, your brain has to say, hey, something's going on here, it's an infection. T cells get going. It doesn't do that. So somebody could have cellulitis, they could have a urinary tract infection, they could have a pneumonia, and really not show signs and symptoms of it. And if you do blood work with them, it might be 3, 4, 5 days before any white count starts going up. So it makes it really difficult when you're working with somebody what exactly is going on here. A little bit about way inside your brain. These are the neurons here. Some people call it a neuron forest because it looks like a bunch of little trees. But the cells, the neuron cells, kind of moving, and they talk to one another. And they talk to one another through this chemical exchange here. And so what happens is brain gets an image of something, boom, it goes boom, 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 and then it sends it back down to the body to say, take your hand off that hot stove, and it's just all very instantaneous. What happens with somebody with dementia, especially Alzheimer's, here you can see that they've developed these plaques and these tangles. So no longer can they communicate with one another. And eventually it leads to death of cells. Here we have a healthy brain. It's got a lot of white matter, it's got a lot of gray matter. It's pretty full. Next to it, we have somebody with Alzheimer's disease. What's the number one thing you notice? It's a lot smaller, okay? It's got big holes going on here. It's smaller in size. So if the brain is shrinking inside the skull, what do you think is filling that space? Fluid, okay? I'm going along and I start to fall. I usually don't have my protective reflexes that I do now. If you and I were to fall, we would put our hands down, we'd probably turn our head to protect ourselves. They won't. They'll just go straight down. Now they're hitting their head and they're getting that brain bouncing back and forth. That fluid is not really a good protective, and now they're the ones that are going to end up with a hemorrhage, and they're the ones that are going to die after a fall that may not even be what you and I would consider much of a fall. But that's part of the reason why. But as they go along, as you see here, this is what we call it, it's brain failure. They physically don't have the brain cells anymore that they had before. So it's not behaviors with them, okay? They can't just stop it. We can help decrease some of the agitation and aggressive behaviors, but we're not going to get them to learn anything new at this point. They physically can't do it. So what are our main areas of concern? It's always safety of the person, of others, inappropriate public behaviors, and then communication issues. Those are our main areas. So safety of the person, number one is abuse. You're a caregiver. You're living with this person 27 or 24/7, and they ask the same question over and over and over again. Where's my wife? Where's my wife? Where's my wife? Dad, she's dead. Oh no, when did she die? So he gets off in this, he gets all emotional, and then he comes out, where's my wife? Where's my wife? Dad, she died. Oh no, and he gets really emotional again and goes, so she's dealing with this over and over again. Well, it's morning, they're gonna have to get off to day services. She's trying to get him ready. She's got 3 kids that she's trying to get off to school. He won't get dressed. So she's trying to get him dressed, he won't. She's going to be late for work. If she loses another day of work, she's going to be in trouble. If she's late, she's in trouble. He starts going, and it just, bam, shut up. Does she mean to be abusive to him? No. But the frustration gets there. What sometimes is a problem is that sometimes situations happen that people think is abuse, and it really isn't. So if I were to come up to you and I'm going to sit here and I'm going to hit you, most likely you're not going to let me do it, are you? So I don't know, you might have just now. But most of the time, if somebody's coming at you and you're going to hit you, how are you going to stop me? Okay, he's well trained. He knows that. Okay, but I'm going to... He's well trained. For most of the time, though, if you're going to hit me, okay, I'm going to stop him, right? And I may end up grabbing both arms because, first of all, I don't want to get hit. And the reaction is you're going to grab him and grab tight because you're going to hold them where they are. Little children have nice fat pads on their arms. You start getting into your 20s, you start losing them. You start getting to my age, you really start losing them. You get to be 80, you don't have any fat pads there. You can see their veins, their tendons. They're great for seeing. I know that they're not great for starting IVs, but you can see them. But that means that there's no protection there. So even though all they're doing is grabbing and holding them so that they're not being hit, what develops pretty soon is you got 4 finger marks, okay? Or the person pulls their arm away and all of a sudden you have a skin tear. So you always want to check them out, and you always want to look at it as possible intentional physical abuse, but sometimes it's a self-defensive bruising that you might see. Verbal abuse, you'll hear that a lot. They just get frustrated and they're telling them to shut up and wish you were dead and you're ruining my life, those types of things, which emotionally hurting to them. Sexual abuse. Both males and females are very vulnerable, so you might see that happening. They're at very great risk for theft and fraud from strangers, which is what you think of, but also family and friends. A stranger drives up and says, hey, I see you're having a problem with the tree. I'll take care of it for you. I happen to have my stuff all here. Tell you what, why don't you give me this much money? I'll go get something and I'll be right back, and boom, I'll fix that tree for you. Oh, okay, how nice guy. He's going to come over, he's going to do it. They hand him the money, they leave, and that's it. How often have you heard that with the building, like the roof, and I'm going to fix your eaves trough? They're very, very vulnerable for that. Family. You'll see that a lot. I'm kind of short on cash today. Well, Mom won't know. Let me write a check out. Grandkids come over. They have a drug or alcohol problem. Well, let's see, she doesn't really need that camera anymore. She'll never remember if I have this necklace. Boom, their property is gone and being sold. Same thing with friends. You'll see that happening, that they will come in and help themselves to some of the property there. Wandering and elopement, very serious problem. Does anybody know the difference between wandering and elopement? Wandering and elopement, the difference has to do with purpose. Wandering is, I go outside and I'm going for a walk down the street. Remember, a lot of times and all of a sudden, I'm 19 years old and I grew up in Kaukauna. I know, anybody ever heard of Kaukauna? And I look around and it's like, wait, where am I? They become lost. They're the ones that we get the silver alert on, that they're going to go to their daughter's house 3 blocks away. They start driving. Next thing you know, daughter's getting a phone call. I don't know where I am. I'm lost. They're 200 miles away. They lose time and space perception. And so they're on the road and they'll just keep going until they can't go anymore. So that's the wandering part of it. The elopement is they're leaving because they have a purpose. Nope, I gotta leave, I gotta go home. Why? My kids are coming home. It's time for my kids to come home. I gotta go home. No, time for me to go to work. I'm leaving. You're not working anymore. Nope, I gotta go to work. If I'm late, my boss is gonna get me, so they're gonna leave. They're the ones that when you go in and out of the unit, they're the ones kind of standing by the door, keeping an eye on things, because they may not remember, but they're not stupid, okay? They can get very crafty on how they get out of places. And then in medical emergencies, you know, somebody's having a heart attack, they can't communicate to you where their pain is. Somebody has got pain, they've fallen, they've broken their hip. The number of times that we've seen people walking on broken hips is just like, and then you feel really bad because they've fallen, you know, they get up and they're able to walk. There's no sign that there's a fracture, displacement, anything. And the next day, all of a sudden, they're really starting to complain about a lot of pain. And maybe they're not moving that leg like they should. So you go get them checked out, and here they had a fracture. But prior to that, no complaints of pain, and they're walking like nobody's business. The other thing is they have a hard time being aware of their feelings in their body. So they may be having pain in their hip. And so you're asking, do you hurt anywhere? Yeah. Where do you hurt? Now they know they're in pain. They can't isolate it that it's the hip. So they're thinking back about where was their pain. Last thing they remember is they had shoulder surgery, and that hurt a whole lot. So you ask them, where's your pain? It's in my shoulder, because that's what makes sense to them, but because of what they can remember. So getting some diagnosis and doing assessment gets very difficult sometimes with those with dementia. Safety of others, physical aggression. You will see a lot of physical aggression when a person is feeling very agitated, very frustrated, very anxious, afraid. So it is a self-protective. Just like yourself, you know that if you were walking down a dark alley and somebody were to come up on you suddenly, you'd start swinging or, you know, get aggressive towards them if you felt like you were in danger. I tell my staff when we're talking about working with individuals and they're combative, it's like, think about it. Okay, you're at home and you're sleeping in bed. All of a sudden, somebody throws the lights on, that disorients you. Somebody's whipping back your sheets. What are you going to think? Is your first thought, oh, somebody came to help me to the toilet? No, your first thought is this person is going to sexually attack me, they're going to physically attack me. Yeah, I'm going to start yelling and fighting back because I'm going to protect myself. So the same thing. So when we approach somebody and you're going into a room, we have to be careful that we announce who we are and what we're there for before we start doing things with the person so that they can process what we're there for. You'll have verbal aggression. Again, that filter's gone and that's their way of communicating. Unpredictable reactions to approach. You know, you've got your EMS uniform on. How obvious, your EMS, right? But you're going up to a gentleman, you were saying the one that, older gentleman who thought he was 16. We are now getting into those who were in the Korean and Vietnam War. There's a lot of PTSD going on, and they were not diagnosed and they were not helped through it. They were basically told to buck it up and deal with it. Now, this is all coming back. And the thing you have to remember when you're working with somebody with dementia, their reality is their reality. Okay? So, if you're going in and somebody says they're 20, they're not just saying I'm 20. They actually believe they're 20. That's why when a husband comes towards their wife and the wife gets freaked out and who are you and what are you doing here? Well, I'm your husband. No, you're not. You're not my husband. She's 20. Obviously, her husband is not this 60-year-old guy. You know, he's 20, 25, he's the same as her. So their reality is where they're at. So you're coming up and you have a uniform on. They may not be able to differentiate what that uniform is. When they think back to uniform, it might have been World War II, German prison guard or Japanese prison guard. It may have been something in Vietnam. They may attack you, or they may run and hide from you because they're afraid of you. So you never quite know sometimes with the approach, and a lot of it has to do with where they are. Animal problems, those are the ones you go into the house and there's cat feces, dog feces all over the place. The animal's really fat because they fed them too much, or it's really skinny because not enough. So that creates a health hazard, a hygiene hazard, not only for them but for people going into the house as well. And then driving. They don't want to give up driving. Their spouses don't want them to give up driving. Why do you think that is? If they're not driving, can they go to the store? Can they go to church? Yeah, that's a huge thing. So even though the wife is sitting on the passenger side yelling directions at her husband on how to get someplace, she's not going to go and say, hey, you shouldn't be driving anymore. Because she wants to get to the store, she wants to get to church, etc. Public behavior, they're the ones that are standing in a store on the corner using inappropriate language, yelling and swearing, calling people choice names. Inappropriate behaviors, they're the ones doing a lot of pacing, they're picking up things, they're touching it, they're going up to people and touching them, and we'll talk about that a little bit more. But behaviors that make people very uncomfortable in the community. And then problems following instructions. If they're asked to sit down, they can't do it. If they're asked to come with you, they can't do that. Communication problems that you're going to see. I know most of you, when you go in, you start asking them questions, correct? About their medical history, about their medications, do they have pain, what's going on? Their answers may make absolutely no sense. Do you hurt anywhere? I have a blue. What? Do you hurt anywhere? I have a blue and maybe a red one too. Or they'll keep saying, do you have pain? Oh yeah. Ooh. Can you tell me where your pain is? I don't have any pain. You just said you had pain. Oh yeah. Where's your pain? I don't have any pain. So it keeps going back and forth. They're the ones that make the 911 calls, the inappropriate ones. I know some of you have been out by us because we've had some residents who have made 911 calls. And all of a sudden you've shown up at our door asking us what the problem is, and we've had no clue. That's because they've been confused, have some memory issues, and decided to make the 911 call. Sometimes they're lonely. So they're the ones that you'll get frequent calls from them because when you came last time you were really nice to them and they're not so lonely. 70% of those with dementia are not living in long-term care, they're living in homes, their own home. The majority of them are living by themselves. And they're afraid to go out in the community, so they get lonely and so they're calling you. Or you're the one that get mad at staff and so they call 911 because you're going to take them to the emergency room and that's going to teach staff. So finally got her to stop doing that one. They have refusals to comply. And again, a lot of it has to do with the fact that one, they're scared. Two, they don't understand what you're asking them. So not only do you have to tell them, a lot of times you have to kind of do some gestures with it. And you can't understand their speech. And you can tell they're trying to communicate something to you, but you can't understand it. So what are cognitive changes that are associated with aging? Number one is normal changes. You have the forgetfulness. We talked about that before. They're slower to learn. So let's say that somebody's going to teach you how to swing a golf club. Okay? You get somebody who's 16, about 20 times, boom, they've got that skill down. You get somebody in their 20s or 30s, 40 times they have it. Somebody my age, 60s, 70s, they can learn. They still have the ability to create those new synapses and those new communications, but it's going to take us like 400 times. So normal aging is you have some forgetfulness, but you remember eventually, and you're slower to learn. With mild cognitive impairments, that's like really the pre-dementia stage. They may have a problem in one area. They're having problems with memory, short-term memory, and maybe all of a sudden they're having problems figuring out how to do their checkbook. When you get into dementia, you have chronic thinking problems. It's even though the pattern isn't consistent, there is a consistent problem in at least two areas. And we had talked about that before, the reasoning, the memory, the ability to do their function, activity of daily living. Delirium mimics dementia a lot of confusion. Somebody with dementia can have delirium, and that can kind of throw things off a little bit. But the difference between dementia and delirium is that with delirium, it's a rapid change. So all of a sudden, they're acting very confused. All of a sudden, they're sleeping all the time. Or all of a sudden, they're not able to walk. Or they're having balance problems, those types of things. And that is a clue that you need to get them some help right away. Depression, that a lot of times will also mimic dementia. And one of the things they're finding now through studies is that if somebody has a chronic problem with depression, especially if it's not treated, they have a very high incident of developing dementia as they go forward. So what are some signs of dementia? Forgetting recent event or new information. Hi, my name is Jan. You are? Susie. Okay. I'm here. I'm going to help you. Oh, that's nice. Who are you? My name is Jan. Oh, okay. Who are you? They can't hold on to that information. So you have to learn to be very patient and repeat and repeat and repeat. They have problems doing complex tasks even if they're familiar. All of a sudden they can't do their checkbook. They can't drive safely. They're kind of all over the road. All of a sudden they're not taking their medications, or they're taking too much of their medications. We see language and communication issues, the repetition of the same story over and over again, the same questions. They can't find the right word. They have problems naming objects, problems understanding what other people are saying to them. A lot of confusion about time and place, people around them, and sometimes who they are. They don't have good judgment. In order to have good judgment, you have to look to see what's going on. You have to hold on to that memory long enough to decide what the consequences of your choices are, and they can't do that. So they just go, oh, I'm going to go outside, and they just go. Never mind the fact that it's -7. They're just in their pajamas. They don't have any shoes on. They want to go to the store, boom, they're just going to go. Difficult with problem solving or reasoning, misplacing or hiding things. They put things in odd places. You know, the remote all of a sudden is in the refrigerator. They don't want somebody to steal their money, so they're putting it under the mattress. Now they go to get these items, they're gone. Obviously somebody's in the house or somebody is stealing from them. You might get that, being accused of taking things from them. They're in bed and they're in their pajamas and you're starting to move them. They don't have their clothes, therefore you must have taken their clothes from them. So don't be surprised if you hear that. Changes in mood and behavior. They can have those mood swings. 1 minute they're laughing, next minute they're crying. Typical personality, you'll see that. And we'll talk about, when we talk about frontal temporal, go into that a little bit more. A loss of initiation, they withdraw from the normal patterns of activities that they used to enjoy. Sometimes it's too much effort, it's too overwhelming trying to remember a simple thing like knitting. Okay? If you've been knitting for a long time, it becomes a muscle memory and you can pretty well do it. But all of a sudden things aren't being processed and they're struggling trying to remember how to do that simple knitting, and it wears them out and they don't do their activities anymore. So the person is confused. Is it dementia or is it another medical condition? There are a number of medical conditions that can mimic dementia, mimic the confusion there. B12 deficiency, hypothyroidism. Now if they're treated, great, it usually goes away. If it's not treated, eventually this chronic condition will lead to dementia. That's why we always encourage everybody, if you're starting to have any concerns, get in, get a full assessment as soon as possible, so that if it is one of these other medical conditions, it can be treated and you decrease the risk of getting dementia. Medication side effects. How many of you ever gone into somebody's house and there's like 15, 20 medications there? Half of them all for the same thing? Yeah. Polypharmacy is huge in the older adults. And those, because their bodies change and they're not excreting like they should, they have the buildup. And then with their kidneys not working right, they get these idiopathic responsive and they get a toxic response. So what you're seeing, that confusion, can actually just mean that there's a medication side effect going on. A hearing or vision loss, again, if you're not being able to see what's in front of you, or you can't hear what's going on, you can act very confused because you're not getting that sensory input that we just take for granted. You know, we don't even think about it. But if they don't have it, they can act very confused. We talked about depression, we talked about delirium. Severe but unrecognized pain. They may not be able to tell us that their back really hurts because they have osteoporosis and they've had a fracture on their back and now it's pushing down on them. That, you know, they broke their hip and they're walking around on a broken hip or their shoulder, something like that. If somebody is in severe pain, they can start acting very confused, especially the longer it goes on. So it's more likely to be dementia if the onset is gradual. If it's not a consistent pattern, you see better days and not so good days, and then it's gradually going to get worse. It is a progressive disease. Some have a straight down, some have kind of a jogged down, but it always goes down. With Alzheimer's, it always goes down, but it's kind of a wavy pattern with some days being better than others. So you walk into somebody's house, you're not sure what's going on. Maybe the person has dementia, maybe they're just confused. Some signs is that they call you, you show up, and they have no idea what you're doing there. Or maybe the family has called and you've introduced yourself, told them why you were there, and they still aren't sure why you were there. If they have medications for memory, such as your Aricept, Exelon, Rezidine, or an Amenda, somewhere along the line, they may not have a diagnosis of dementia, but some physician realized that there were some memory problems going on. These medications will not cure, will not stop it, but it will slow down the progression. So if you see any of those medications, it's a good chance that somebody thinks that dementia is going on. Some other drugs that might also indicate are your antidepressants, mood stabilizers, antipsychotics, anti-anxiety, and your benzodiazepine. These medications are used to treat the symptoms, the agitation, the anxiety, might be the verbal outburst, might be the physical aggression. So especially if you're seeing anything like Aricept and one of those medications, it's a good indication that person has dementia. If you see prominently displayed contact information, you know, this is your daughter, I'm your daughter, here's my name, here's my phone number. It's by the refrigerator, it's by the phone. If you're seeing those types of things, it's a good indication there that they're having memory problems. Medical alert bracelets. Some of them will get the medical alert bracelets that says, I have dementia, I have Alzheimer's. The Alzheimer's Association now has some bracelets out. I haven't seen a whole lot of them yet, but you might see something that has the Alzheimer's Association on it. Alert technology. Does anybody know what I mean by that?
Lifelines.
Yep, they have the lifelines. You go and here's this little stick on the door, and you open up the door, and the voice says, "Mom, it's still nighttime. Go back to bed." So, and you'll see that on the outside doors. You may see them alarms by the windows. Something that will help kind of alert that they're trying to leave or there's a safety issue. You might have a medication box that will say, "Oh, it's noon, time for your pills, Mom." And then it will open and have the pills right there for it. So those alert technologies and any of those assistive technologies can kind of give you a clue that something's going on. So if we kind of talk about some of the different dementias that are out there, as I said, there's over 100. The five main ones that you will come in contact with are most common. We're going to go into a little more depth and kind of look at them side by side. The Alzheimer's, number one thing when you think of somebody with Alzheimer's is the short-term memory loss. They have problems finding words. They're very impulsive. They use poor judgment, problems making decisions, get lost very easily. And then these are gradual changes. It doesn't happen overnight. The vascular dementia, these are the ones that occur most often after a stroke or TIAs. You'll see sudden changes going on here. Somebody with Alzheimer's is at a higher risk of the vascular dementias as well. They can go hand in hand. And if you see more than one type of dementia together, you'll hear that being referred to as a mixed. It's an inconsistent pattern. Most of those with Alzheimer's start with your memory, and it's a pretty clear pattern. You can kind of tell what stage they're in as what kind of symptoms, because you know what part of the brain is being affected. Here, it can be anywhere. It can start with short-term memory. It can start with word finding. It may start with the ability for muscle control. It depends on where that clot is and where the stroke is affecting. They'll get poor judgment. The behavior is not the same. You'll hear that a lot. You may not be able to put your finger on it, but I get that all the time from my direct care staff. They're just not the same. Whether it's a medical illness or if it's TIA or something along here, you just know something's different. They have a lot of problems planning and organizing. They can't get their thoughts together long enough to sequence. And then these are the ones you'll see the mood swings with, very rapid mood swings. Lewy body dementia. There are proteins in the brain that start clumping together, and those are called Lewy bodies. And this is the one that's going to cause you, as I said, a lot of their most challenges, because they're the ones that have a lot of behavioral issues. They have some muscle rigidity, sometimes look like seizures. They will have some of the memory loss, the muscle and movement problems. Sometimes they look like Parkinson's. They're the ones that have the visual hallucinations, and so they're the ones that you've got the agitation and the physical and the verbal aggression because they're seeing things that you and I don't see. They have a lot of sleep disturbances, a lot of nightmares. So along with this, they end up with sleep deprivation. So you and I know that if somebody has sleep deprivation, you're going to get a lot more of the behaviors. It increases the hallucinations, etc. So it's kind of challenging. They have fluctuations in their abilities. Today, tomorrow, I can do really well. I can brush my teeth. I can feed myself, no problem. Then it comes along, it's Sunday, and I can't figure out how to brush my teeth. I have problems controlling my muscles to do it. So theirs is not a straight, theirs is very, and then they go up and down and all over the place. These are the ones that a lot of times have the idiopathic responses to your drugs, and they have severe reactions to their drugs. So somebody's agitated, let's just give them a little Ativan, let's calm them down. boom, they're shot off the wall, and they become very agitated and things. And that's because of the response to medications. These are the ones you really want to stay away from, a lot of the psychotropics, anti-anxieties and things. The frontal temporal dementias, these are the ones you're more likely to see out on the street. These are the ones that you're going to see in your peers. Most of those with early onset dementia have the frontal temporal. And there are multiple types, but the key factor with this is you get the behavioral personality changes that you don't see as much with the early stages for the other dementias like you do with this one. Remember when we talked about the frontal area here? That's the impulse and the behavior control. So all of a sudden this nice gentle man is saying really rude things to those around him. They're mean, they're nasty all of a sudden. They just say odd things out of the clear blue, and you can't quite figure out what's going on with this person. They become disinhibited. They will all of a sudden start eating more or not eating. They may concentrate and just eat sugars, or they just might eat fats. Sex, they all of a sudden become very promiscuous. A strong family man all of a sudden is going out and having affairs. A woman who rarely ever drank is going to the bars, getting drunk, going home with other men. Emotions, they're not, gentle swing. I mean, they're huge swings. If they're angry, they're angry. If they're sad, they're sad. If they're happy, they are happy. They're extremes. They become stuck or obsessed about things. They get this OCD behaviors. Like we said with the food, all of a sudden they like a lot of sugars and they'll concentrate on just eating the sugar foods. The temporal is the language. They can't speak, they can't get the words out. A lot of times you can't understand what they're saying. They're the ones that do the word salad. And word salad is they'll put a bunch of words together that have no connection, no meaning, and then you're trying to figure out what they're saying. They're the ones that are more likely to have more violent behavior, more aggressive behavior for that. And they're younger and they're a little stronger. The issues that we come across, the main one is the memory, and that's when we think about someone with dementia, that's what we think about. A lot of times they don't know where, when they are. And when we talk about when, I said, if they think they're 19, they are 19. They're not sure what's going on. A lot of times they don't know where they want to go, and they don't know what they want to do. They just know that they have to go somewhere or they have to do something. What they are still able to do is to confabulate. It's not that they're lying to you when they tell you, their little stories and things. I always kind of picture it this way: is you've got a picture and you ask them a question and they look at the picture to try, a memory picture. And they look at the recent events and it's totally grayed out. They can't see anything. So they turn to the next picture in the book. It's still mostly gray, but there are a few things that you can see. And they keep going through the book till they finally get a whole picture. So somebody who used to do a lot of traveling with their daughter, and she did a lot of flying, so she spent a lot of time in airports. So all of a sudden she's in this room, there are a lot of people. She doesn't know why she's in the room, she doesn't know who these people are, so she's going to kind of go back in her mind to get that picture. Well, boom, the first picture she gets that's whole and makes sense to her is the airport picture. So that's why all of a sudden you'll find out that she's sitting in an airport, and that becomes her reality. The thing we'd like everybody to learn is that we can't get them back into our reality, but we can go into theirs, and it's a lot more fun in there, and it's a lot easier. So rather than say, no, you're not in an airport, it's, oh, you're in an airport. Tell me about the airport. So if you can get them to kind of expand on that, a lot of times while you're trying to work with them, if you can get them to talk about what's going on in their mind and where they are, you'll distract them enough to be able to do what you need to do, whether it's blood pressure, IV, anything along those lines. A lot of the emotional memories. Emotional memories are really strong, and they're the ones that stay in the long-term memory. So they will have those. They may not remember who their daughter is, but they know that there's a connection there and there's a special connection. So even that nice lady from across the street, who's her daughter, she likes that lady because she knows that there's an emotional connection. And then motor memories. Brushing their teeth, to use that one again. You may hand them a toothbrush and they don't know what to do with them. If you can get them to bring it up to their mouth and start it, once they start it, then they can remember the rest of the steps. Understanding there are issues related to that. They can't interpret information, so especially if you're giving them a lot of complex information, they can't hold on to it and sequence it enough to really understand what's going on. And a lot of times we can't make sense of their words, so the communication becomes difficult. What they can do is pick up your facial expression. Body language is hugely important when communicating with anybody, but especially somebody with dementia. They may not understand what you're saying, but if you've got a relaxed body, you're acting calm, you're talking in a friendly, calm tone of voice, they're going to pick that up and they're going to react to that. And the tone of voice, you know, I can say, "Well, how you doing today?" versus, "Oh, hi, how you doing today?" Both of them are the same words, but that sharper tone versus that latter tone, they're going to respond to that latter tone because it sounds friendly. The other one doesn't quite sound so friendly. Even both of the words, you know, all the words are friendly. Language issues goes along with communication. They can't find the right words. They can't say what they mean, and you'll see this all the time. They're trying to explain something to you and they can't find the words, and you can just see the frustration and the fear in their eyes. And so because they can't communicate, they can't let you know what their needs are. You may see agitation, and it might not be related to not feeling well. It might be that they're cold or they're hot or they're hungry or they're thirsty. They need to use the bathroom. What they still can do is their automatic speech, and you'll hear that a lot. Automatic speech is that, as I'm talking, well, you know, it's, you know, like when, it's all those little filler words that you use in that conversation. You don't think about them, they just come out. So you'll hear all these little sounds and stuff. So you'll hear those still. Singing. They can't speak, but they can sing. We have one person who is pretty nonverbal. Every so often she'll come out with some words that you can understand. You put on a music or a song that she knows, and she will sing it, and she can sing every word. We have one person who has a walker. We need to assist her with walking. If you put a polka on, she can do that polka. And she is just as steady can be. So rhythm remains with them towards the end. So a lot of times what I find, if I'm trying to work with somebody and they're agitated and I'm trying to get them to calm down, I will start humming something. Especially if it's a fairly common song, that will help sometimes relax them. And the other thing that they can do is swearing. Don't take things personally. A lot of times it just comes out. The sensory changes, they have problems realizing their body and position. That's why they have more frequent falls. They have problems telling you where their pain is. And they can't isolate the feelings. So they can't tell you if something's sharp, if something's dull. They just know that it's pain. They have 4 main areas that remain sensitive. And you might get some reactions as they deal with these. The first one is the mouth. You know, like a little kid, and you explore something, everything goes into the mouth. That still remains very sensitive. So they may do a lot of this, or you're maybe going to listen to their heart, and they take your stethoscope and it goes in the mouth. You may see something along that line. The other place is your fingertips. Okay, so they're the ones that they're going to come up and you talk to them, and they'll start touching things because they want the sensation. They're the ones that they do this on the table. It's not that they necessarily want your attention. It's not that they're trying to make noise, but when they do this, they're getting sensation on their hands. They're the ones that you help them sit in a chair and they start leaning forward. And it's like, no, sit down. And they keep leaning forward. And what it is they're putting pressure on the balls of their feet, the third sensitive area. So they're the ones that you worry about, because a lot of times as they're leaning forward, they keep going. They don't have the ability to stop themselves. And then the last area is the genitalia. So you might see inappropriate behavior by them touching themselves. They may touch you inappropriately or attempt to. And it's not necessarily that it's a sexual kind, but it is an enjoyment. It feels good. So it's like a little baby. All of a sudden they discover themselves and it's like, oh, this is nice. It's the same thing for them, because that's an area that remains sensitive. Impulse and emotion, they can become very labile in extreme emotions. If they think it, they will say it. If they want it, they'll just do it. And if they see it, they'll just use it. What is preserved is the desire to be respected, to be in control. And that's like with anybody. We want that, whether we have dementia or not, whether we're 2 or we're 80. And the other thing you'll see a lot of time is the regret. They've said something, they've hit you, they become very sorry, but it just came out because of the impulse control. So we need to think about safety. They may not know what's going on. You may go to an emergency scene and they're standing in the midst of all the action. They refuse to come out because of the fire, something along that line. They just don't understand what's going on, so they're not removing themselves from danger. The other thing, they might think they're in trouble. They see the police officer coming, they see you coming, they see a uniform, they think they're in trouble, and they're going to hide. Emotions seem to be out of context, but what we have to remember is their emotions, it's their experience, and just go with it and let them express it. The thing is, don't attempt to restrain unless safety issues are present. I'm not going to say don't ever restrain, because there are just some times that you need to. But if you can get away without restraining them, you're less likely to see the agitation, you're less likely to see the aggression. A lot of times what I suggest is, if you have the ability to do so, if you have one person be that person's connection, and you stay by them and your sole job is to be their connection, you can do a lot of things without having to do restraints. So if that's a possibility, do it. Obviously, safety issue, go ahead and use the soft restraints. And then be aware of the signs of stress or frustration. If somebody's feeling very stressed, you'll hear a lot of repeated questions, repeated statements. They'll be sitting, maybe wringing their hands. They'll start getting restless. They'll kick their legs or move their hands a lot. If they start asking for mother or spouse or a loved one, a lot of times that's a good indication that they're not feeling secure. They're feeling afraid. So if they start asking for mom, like you and I, mom meant comfort to us. And so kind of sometimes don't listen to the words, but what's going on behind them. If I start hearing this is when I start reassuring them a lot that they're safe and I'm there to help them and protect them. The loss of inhibitions, they'll start saying and doing things they wouldn't normally. The suspicion. Okay, they're hurting, you're there, they don't know you, therefore you must have done something to them. Again, as I said, you're taking them out, they don't have their clothes on, you stole their clothes, you stole their purse, etc. Misperceptions of the situation, we kind of talked about that, not understanding. And so they're going to go back and they're going to put a context to what's happening that makes sense to them. And then eventually you will get to the point of aggression if we're not meeting their needs. So the possible causes of aggression is they don't recognize where they are. They're lost in their time and space. They don't recognize people around them. If you've got a bunch of people around you who are doing things to you that don't feel the best, you're going to get a little anxious. Too much stimulation. As much as possible, if you're noticing somebody starting to get agitated, if you can turn down the lights, turn down the sounds, get as many people out of the room or out of the way as possible. That helps. If they're ill, if they're in pain, hot, cold, hungry, thirsty, they need to use the toilet. If we're not meeting that need, they get frustrated and they may become aggressive. And the last one, which is the major one, is they're afraid. So what we want to do is try to determine the cause. Sometimes you can, sometimes you can't. And then generally I just assume they're always afraid, and I start reassuring them that they're safe. You want to reduce as much stress as possible, explain what is happening, and use their name. If you're using their name and you're telling them their name, they're feeling like, if they know my name, we must be friends, or we must know each other, and that helps decrease some of the agitation. Give them time to respond. It's the hardest thing. It's still a hard thing for me. I have to consciously work on it. If you ask them a question, count to 10 and give them time to respond. If they don't respond, or they don't respond in a way that you can understand, ask them again and use the same words. If you keep changing the words, they have to reprocess each time. So the more that you can use the same words, the more likely you are to get an accurate answer. It gets irritating, but try not to show that and don't confront them. Include their care partner if available. Sometimes they can be very calming. They may know some tricks, they may know some triggers going on. Sudden movements, especially if you're coming from the side, is very frightening to them because of visions. And then using a low, calm tone of voice. What I do if somebody's starting to get agitated, if they're screaming, they're yelling, I certainly don't yell back at them, because that's not going to accomplish anything. But what I do is I make sure I'm standing in front of them with enough distance that they feel like they can get around me. Or I'll stand so that they can see me if they're laying in bed. And I drop my shoulders, because that's automatic, shows that I'm relaxed. I keep my hands kind of open like this, because obviously I have nothing in my hands. I'm not threatening to them. And then I drop my voice. Because if somebody's screaming and yelling, and I'm dropping my voice, their thought is, what are they saying about me? So they start to become quieter because they want to hear what I'm saying, because I might be saying something that's not so nice. The other thing I start doing is talking real monotone, because as I'm talking real monotone, it's going to start slowing down their respirations, their heart rate. They're going to become less agitated. This has worked with a lot of agitated individuals. It's also worked for some. I've talked people out of asthma attacks just doing the same thing, because people start to listen and their body language starts to match mine. So it's really helpful. So try to recognize what the problem is going to be, but realize you're on a time limit. You may not figure out what it is. You may never know what it is. Be willing to try something different. You always have somebody sit down or lay down to do a blood pressure, and for some reason they're walking around and they won't. You may have to learn how to do a blood pressure with them walking. We'll talk about the positive physical approach in just a minute, and then the positive communication skills as we go forward. So when we do the positive approach, everybody moved around here. Come on up. Okay, so I'm coming up to him. He's kind of agitated, or
He looks agitated.
yeah, doesn't he? Wait till you see him come. He'll be on the floor. Let's say that you're in a situation and they've called because he's been acting like he's having chest pain, and they think maybe he's having a heart attack, but he's still walking around, and you're in there and the daughter's saying, I think he's having a heart attack, or his behavior is so, I need some help. And he's going, no, 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 she's lying, don't listen to her, I don't know who she is. And you want to get him away from the situation. He's not coming with you, okay? One of the things you can do is go up to him and say, hi, I'm Jan, how you doing?
I'm Taylor.
Good, good. I'm glad to hear you say that. One of the last social cues to go is this right here. It's an automatic. Even if somebody's really agitated, if you go up to them and hold your hand and let them come to you, they will almost always put their hand out to you. So now I want to, if I'm standing here, first of all, he can swing and hit me if he wants, okay? Don't want him to, but he could do that. Plus, if I'm saying, okay, I want you to come with me, who's in his way?
You.
Me. Visually, he can't see what's going on. The other thing is I'm cutting off him and I'm cornering him. So as I'm talking to him, what I'm going to do is I'm going to take my hand and I'm going to switch it like this. I'm going to step to the side and I'm going to stand here like this. I'm going to turn a little bit here. Okay, there you go. So I'm going to stand here. You notice I'm underneath, but I can control his hand. But he has control because he's on top. The other thing I want to do is I want to put my hand here, I want to put my hand here, because that will help disconnect what's going on in his brain. Okay, and it also grounds us together. So as I'm sitting here and he might be agitated, I can say, okay, now let's just go over here, and we can walk him over here. If I'm sitting here and I want to get him to pay attention to me and he's still yelling at that person over there, a lot of times if I take his hand and I just do this squeeze here, the reaction is that right there. He's going to come, he's going to look at you, and now we can connect. The other thing is now if he starts doing his little dance, or if he starts trying to swing at me, as he's swinging this way, you notice how I can just kind of stay behind him, and he's not going to get to me. And eventually, hopefully, as he's bringing his hand up, I can get his hand like this, but I'm going to do the same hold, okay? And I'm here, I'm like this. And I can get his elbow here, so his ability to swing and hit me really decreases. So that's great when you go into a situation, you're trying to get somebody moved, but it will also work for somebody in bed. Thank you, you can sit down. Thank you. So if somebody's laying in bed and you're trying to get the same thing, what you can do is you can come up to them, offer their hand. I'm not going to make you lay on the table. I'm going to offer their hand, take the same grip, going to move to the side and touch their shoulder. Okay? Somebody's wanting to do blood pressure on them. Having you ground them and talk them through it, a lot of times you're going to get compliance you won't otherwise. The other thing is you're holding. If you put your hand underneath the elbow, they can't bend and pull away as easy. But it's not like I'm sitting there and I'm holding them, which is probably going to make things worse rather than better. So, you can go ahead. Okay. So this works whether the person is standing or sitting. It works really well. As we did, I introduced that way we're friends. I'm not a threat to them. You know, my name is here. I don't know, what do you say? I thought about this. You know, I'm an EMT, I'm with the ambulance, you know, whatever the terminology they're going to know, but I'm some kind of a medical person. I'm here because, and let them know, I'm here because you're not feeling well. I'm here because you said you hurt. I'm here to make sure you're safe. You know, if somebody's really agitated and they're denying that you should be there, just let them know, I'm here to make sure you're safe. Show them your badge. Sometimes that works real well. Sometimes it doesn't. And then just really showing by body language that you're calm. Give them time, count to 10. That helps give them time to let you know if they're processing and how easy it is for them to process. But if you also give them that time, it lets them know you're listening to them. And that is the thing that they say is so frustrating, is nobody listens to me. And by giving them that little response time, they feel like they're being listened to, which feels like they have some control. Go slow. We just showed this, get to the side, and that's called the supportive stance. When I'm standing there on his side, I'm holding and I'm supporting either up on the shoulder or by the elbow. It works best if you're on their dominant side. You can do it either side, but if you know their dominant side and you're on that side, it's much more effective with them. Get down low. If a person is sitting down or if they're in their bed, get down to their level. If you're standing over them, that becomes very intimidating and it's frightening for them. And as I said, when you're holding that hand, it gives you protection from being struck and from them hitting out. So we want to use this when there's not an immediate danger and you don't, if you need to get them out now, don't worry, you're going to get them out however you need to get them out. But if there's some risk that the person is not understanding what he needs to do, is confused about where to go, there's problems with the caregiver, person's just totally disoriented, this is a good time to use these skills. With communication, positive communication, it gets the person to do something. Okay, it involves them, it gets their mind off of what else is going on, and it helps deal with stress that are going on. So again, we want to introduce, get their name. If you ask them who they are and you know what their name is, it lets you know if they're in their reality. The other thing, if they start making some strange comments, ask them how old they are, and they'll tell you. She's 88, and when you ask her how old she says she's 35. It explains some of the agitation, it might explain some of the statements that she's making. Offer short, simple information about the situation. I'm Jan, I'm here to help you. I'm Jan, I want to take your blood pressure. Just very simple and very short. Lets them know what's happening, it's not so frightening, and it sets it up for what's going to be coming up. As I said, use short sentences, simple, concrete words. They have problems with abstract thought, so you have to be very concrete with them. Accurate, honest information, okay, as far as what you're going to be doing. If you're going to do blood draw, if you're going to start an IV, let them know. If they say something to you about, oh, you must be my husband, or where is my husband, and you know he's dead, don't tell them that. Okay, because that's just, they will act like they are learning it for the first time and go through that grief. But anything you're going to be doing with them, where you're going to be taking them, be honest with them with that. If you have to show pictures or objects, if you're going to do their blood pressure, show them the blood pressure machine first and tell them this is a machine that will check your blood pressure. I'm going to put it on your arm. If they see things, they can understand it better. Another thing you can do is ask for help. People love to help. So if you can't get them to do a blood pressure, just tell them, I need to take your blood pressure for my job. Can you help me by? Hold your arm. You're trying to get them out of a situation and you need them to move. Hey, can you help me go get my bag? And if they think they can help, they're more likely to go along and do what you're asking them to do. So, having a conversation, if you're trying to figure out how to distract them, what to do, go back to long-term memory information. Where do they come from? What did they do growing up? Who's in the family? Do you have any children? What are the names of your children? So things that they can go back into long-term memory. Doesn't matter if it's right or not. It gives them a connection to your emotional connection that makes them more likely to comply with what you're asking them to do and less agitated. And then use some of their words in your responses. Again, that helps them connect. So if they say, I lived on a farm. Oh, you were on a farm. Yeah, I grew chickens. Oh, you had chickens. Yeah, we used to eat the eggs. Oh, so you ate. Doing that, it helps them ground and it kind of keeps them going and concentrating on what you're saying. When you have a conversation, remember, they're not going to be 100% accurate. They may not even be 1% accurate. But they have those emotional memories and they're connecting them with you because you're showing that you care. They remember old stuff really well. It may not be the correct order. It may not be during the correct situation, but they remember that stuff. And if they can't figure out what's going on, they will make up a scenario that makes sense to them so that they can understand their specific feelings at this time. So when we deal with distress, we want to consider our approach, our body language, what language and words we're using. Are we simple? Are we short? And then any environmental stressors going on. Look around to see, do we have too many people in there? Are the lights too bright? Do we have too much equipment in there that looks scary to them? You want to remain calm. That's the number one thing. If you want somebody else to be calm, you have to be calm. We want to use a positive approach with them. Don't argue with them. You'll never win an argument with somebody with dementia. They can out-argue me, and my husband says I'm a pro. So don't even bother trying. Just go with the flow and go into their world. The more you rush them, the more stress they feel, the more likely you are to cause agitation and aggression. Keeping the noise down decreases the anxiety. Sometimes you have to move to a new location or do a different activity to get them to connect to you. Number one thing we do a lot is the jargon. Use everyday language, especially very simple ones that might mean something to them. You know, being an older person, that doesn't mean the same thing to us. So some of the communication challenges we might see is that they repeat the same word over and over and over again. So you're asking them questions, you just get the same answer, or you get the same question. They will answer you with totally nonsense words. They may call you by somebody else's name. And I just go with the flow. You know, some days I'm Mary, some days I'm Jan, some days I'm Carol. I was Bob one day, and I thought, okay, that one's kind of scary. But I just answer to whatever name they call me. Keep repeating what you just said. And as I said, don't keep changing the words. Keep the words the same. Each time you say it, they're able to process it a little bit better, and hopefully at some point it will click and they'll understand what you're asking them. Some of the confusion challenges you see, they have problems finding the right word. They can't understand complex instructions or questions. You can't tell them to do 3 or 4 steps in a direction. You have to do 1 step at a time. Okay? I need you to go over and sit on the cot and lay down. You can't. I need you to stand up. They stand up. Okay, we're going to walk to the cot. You go there. I need you to sit down each step as they go along, because they can understand that. They'll get tired very easy. It gets too overwhelming for them. So you're trying to do something with them. You're trying to talk to them. Just, no, I'm too tired. No, just go away. I'm too tired. Just go away. The illness, injury, and pain will increase confusion for them. Anytime you have changes in the routine, familiar people, objects, that really will increase their confusion. So things when you take them from their home and you're going to the emergency room or their hospital, there's a thing called transfer trauma, and it will increase confusion for them. So somebody who's got some mild confusion all of a sudden may be presenting with a lot of confusion, and that's because of all the changes going on. So the main thing you want to remember when you're going through this is the handoff. Make sure that when you're taking them to the emergency room or wherever they're going, that if you're leaving them or when you're leaving them there, pass on any information that you have. He says he doesn't have dementia, however, he's on Aricept and things, so I think there's going on. He is showing some confusion. I found out that when I said, that helped calm him down. When he got really agitated, I just kept telling him he was safe, and that helped her. Those types of things. So anything you've learned about this person, any techniques that will help them, you want to share that information. I know that's not a usual communication that you do with them, but if you have that information, they are going to be able to interact better with this person. This person is less likely to be put on some type of anti-anxiety psychotropic to control behaviors, which means they're less likely to have medication reactions or to fall. So that's an important part of the handoff. With all this, what we're asking you to do, which you're helping right now with coming to this class here, is that you commit to become dementia aware and dementia friendly. We want to get rid of that stigma. We want to let people know that dementia is not the world's best disease. Okay, it's not pleasant. It's not easy for them. It's not easy for any caregivers. But it doesn't mean they can't have a good quality of life. That means, it doesn't mean that they can't have their moments of joy and happiness like you or I. We just have to learn how to communicate with them so that we can offer this to them. So we want pretty soon that it's not the, oh, they have dementia. I have one person who I said, why don't you please come to the Memory Cafe? You would really enjoy it. She goes, no. My husband was a pillar in this community. I don't want anybody to see him like this. Occasionally he has some problems finding words. Loves to sing, so occasionally he'll just start singing at the top of his voice, but he's got a good voice. But because he was different, she doesn't take him out in the community at all. So now he's isolating, and a lot of times she's isolating because she has to take care of him. So we want to get rid of that stigma. We want them to go out and enjoy. And we want to make sure that it's something that they have and it's nothing that defines them and who they are. So thank you very much. Any questions that you have at all? Any thoughts? Nothing? Well, thank you very much for paying attention. I appreciate it. Did give you, as I said, a couple different handouts. It has more information. We could do this all day long. And because there is so much information, it's just kind of a little refresher for what I have here. If you have any questions, my contact information's on there. Craig knows how to get a hold of me. I'm more than happy to answer any questions, help any way I can. Thank you very much.
Thank you.